third ଓ ତମଟା ସୋମରା କାଉଣ୍ଟ କରୁଥିଲା ବୋଧେ
So can we start?
Yes, sir. Please proceed.
Good evening, everyone. On behalf of Indian Association of Physical Medicine Rehabilitation and Association of Physical Medicine Rehabilitation of Odisha, a warm welcome you all for today's webinar. Today's webinar is on rehabilitation in critical care unit, opportunities and challenges. Really, it is a burning topic in the current scenario. Most of us may not have that exposure of working in corporate sector, especially in critical care units. And many of our young physiatrists are going to work, or some people are also working in the critical care units, where this update of knowledge of these things are very, very essential. I hope today's webinar will enlighten many things about critical care units. Really, there are a lot of opportunities to work in the critical care unit, and there are a lot of challenges also. It's because most of the time, the in charge of the critical care unit is a anesthetist who takes care about the vital status of the patient, and many of times they forget about the associated complications related to ICU or ventilation things. The most of the problems associated with are like mobility, cognition, ADL, and when the patient stay in a long period in mechanical ventilation, there is, although the patient survives, but there are overall increase of morbidity. So there is a condition called ICU acquired weakness, which is usually happen. I have also gone through the literature. It is shown that 25% cases develop this ICU acquired weakness even 7 days after admission to ICU, and the 50 to 60% of cases, this weakness persists for 3 to 12 weeks, even to a month. So this is a challenge for us. Everybody ignore about that thing, but as a physiatrist, we should take care of those parts, those long-term complications associated with the admission to critical care units. And there is always a sustained diffuse weakness, and there is weakness of the extremities, involvement respiratory muscles, diaphragm. So this is our job to take care of that part to prevent this ICU acquired weakness. Today's webinar will, I hope, there are a lot of things to discuss by the Dr. Koustubh. So before going to the topic, I would like to welcome, it's a privilege for me to welcome the chairperson of this webinar, Dr. Peerless. He is the president of IAPMR and currently the professor of Department of PMR, Koustubh Medical College, Chennai. And he has been a long experience of working in corporate sector also. As his CV shows that he has worked in Saudi Arabia in Paras Hospital for 2000-2005. Sir, you must have a long experience on that, 5 years experience in that. And besides that, he has been served in various positions in medical college, and also he has worked consecutively 2 terms as secretary of IAPMR, and there are a lot of things on his credit. Sir, I welcome you to this webinar. And today's speaker is Dr. Koustubh Chakraborty, is a friend of mine, and he has also a long experience in working in corporate sector. He is currently working in the Peerless Hospital, Kolkata. His area of interest is pain management and a lot of things, cardiopulmonary rehabilitation, the important part which we mostly neglect, and rheumatological and soft tissue injury rehabilitation. He has a lot of publications to his credit. He has written a book chapter also, He has a list of achievements, like he has received this Dadichi Award for Best Speaker, Overall Speaker in IAPMR Con 2017 held at Patna. And he is a best speaker in interdisciplinary seminar of low back pain organized by postgraduate academic at IPGMER, Kolkata. And he is a recipient of National Talent Search Scholarship in 1995. So he has a long experience working in corporate sector. I hope his speech will clear a lot of doubt from our mind. Before coming to the topic proper, I would like to request the chairperson, the president of IAPMR, to say a few words about this webinar. Over to you, sir.
Thank you, PK Sadhu sir. Actually, I have to really appreciate the initiative taken by the PK Sadhu sir for the academic program for the postgraduates and young students. And when the initiative was taken up about a few weeks back, the executive committee and IAPMR was very appreciative of it. And even our academic committee chairman Joy Singh was very eagerly appreciated and approved the program. And Amit Ranjan, our PR team, also taking it initiative, forwarding and communicating to all the members. And this is in this regard, first I would really thank and appreciate because for all the initiatives and the commitment for a regular academic program for the students and various angles and various aspects of our PMR. And the Odisha chapter of IAPMR chapter as well. And today, one among the continuing program, this continuing medical education program, and our Koustubh Chakraborty sir from Bengal chapter has taken the initiative to deliver the lectures as P.K. Sadhu sir was talking about the challenges and opportunities in critical care. And I really know our Koustubh sir has worked in the Peerless hospital in the ICU, and during the COVID pandemic, I was listening to him a lot of the challenges that he was talking about, and that could be, I think, there is an important time for him to express or to deliver his experiences about the challenges he faced, and also the opportunities that we will have as a PMR person during the ICU care. And I'm eagerly waiting for your lecture as our students and faculties, our delegates are waiting for lecture. And I'll wish you all the best for a wonderful lecture. Back to Sagu, sir.
Thank you, sir, for your kind words. Now I will request Dr. Koustubh Chakraborty to start his presentation.
Thank you so much, respected chairperson, sir, and my dear friend, Dr. Shahu. Thank you so much for giving me an opportunity on this very special day to deliver this lecture. And it's a day of great joy for us. And I'll start off by congratulating our athletes who have won laurels for India. And let us do our little bit to help our country in whatever way we can. So is my screen visible?
Yeah, yes, visible, yes. Sir, visible.
Okay, so let me start. From all the physiatrists, we salute our great heroes who are bringing back laurels. And with that, we shall start the rehab in ICU. What are the opportunities and challenges for a physiatrist? And as usual, I think there is, yes, it's there. So, why do physiatrists need to be in the ITU? What are the things we need to do? And how to solve the various challenges that crop up? So, this shall be the theme of my talk. Firstly, why? Because fight back starts immediately after the patient has stabilized, and his return to normalcy will be in our hands. There is a great morbidity associated with ventilation, weaning failure, and with prolonged hospitalization. This is where physiatrists can also help in reducing this burden. It's been shown that there has been a decrease or a delayed return to work rates due to deconditioning as well as delirium suffered during this ITU stay. The faster the person returns to work, he or she would be more economically productive or an active member of his family or society. Add to that, in the private sector, the high cost of treatment, or for the country, a high cost of treatment in maintaining the ITUs, in the patients in the ITUs. And as we have seen in this COVID situation, there is a shortage of ITU beds. We need a higher turnover of ITU beds. So our intervention as physiatrists will help in achieving that. Okay. There seems to be a little problem in transition of slides, but finally it is there. So what are the goals of rehab? Number one, improvement of mobility, which Dr. Sahu had pointed out. Second, avoiding the preventable complications which are associated with prolonged bed rest, such as pressure injuries, deep vein thrombosis, atelectasis, and postural contractures. Reducing the deconditioning which is associated. We shall go into a bit more detail of deconditioning. Management of respiratory secretions, which will help in extubation of the patient or weaning from the ventilator or tracheostomy, as well as minimizing the chances of delirium associated with ITU, the critical illness myopathy and critical illness polyneuropathy that inevitably accompanies a prolonged ITU stay. Bear with me for the change of slide. Okay, so types of physiatric intervention. Number one, as physiatrists, we need to assess the stability of the patient for rehab. Second, pain and spasticity management, respiratory secretion management, as well as oxygenation management, as I've spoken previously, delirium prevention, advice to the nursing staff, the physiotherapists, including advice for early mobilization, speech and language pathologists, and prosthetic and orthotics persons, if they are applicable in this patient's case, and also advise the dietitians, occupational therapists, and if respiratory therapists are associated, we have to advise them on the ventilation management. Coming to deconditioning. This is caused by an immobilization as a result of prolonged bed rest, resulting in reduced functional capacity of multiple body systems, principally the musculoskeletal system, which is our bread and butter. Wikipedia, interestingly, has a very wonderful short definition. It says, deconditioning is the decrease of physiological adaptation to normal conditions. That is, the body is functioning, but at a lower level of function, of physiological capacity. It affects the musculoskeletal system, cardiovascular system, respiratory, the integumental system, GI tract, genitourinary system, metabolism, endocrine, as well as it affects cognition, leading to delirium. What are the musculoskeletal changes? Number one, contractures. Number two, muscle weakness and atrophy. And we know that in the anti-gravity group of muscles which are resting in a prolonged bed rest, the loss of strength might be as high as 1 to 3% per day, or 10 to 20% decrease in isometric strength per week. So this will translate to a 50% loss of strength in 3 to 5 weeks of immobilization. And associated with diffuse osteoporosis and cartilage degeneration, our entire musculoskeletal system, the bones, the joints, the muscles are functioning at a lower level. What's more, strength lost in 1 week takes 4 weeks to recover. So that much more time is required for the person to recover before he or she becomes a productive member of the society once again. So as you can see in this picture, this patient's intercostal muscles as well as the paraspinal muscles of the back are grossly wasted. And perhaps you can appreciate the fixed flexion deformity in his hips also from prolonged, I should say, neglected stay in the critical care unit. What happens to the CVS? There will be postural hypotension, which will cause difficulty in mobilizing the patient either to sitting or standing position. There's an increasing heart rate. There's an increase in stroke volume with an increase of left ventricular end diastolic volume, causing a decrease in the reserve capacity. Blood volume has been found to increase, and in long cases, cardiac size has been found to increase by 11%. In the respiratory system, we get a weaker cough effort. There's a more propensity for infections, for ITU-acquired infections, for ventilator-associated pneumonia due to decrease in range of motion, both at the costovertebral as well as the costochondral joints anteriorly. There's a decrease in strength of diaphragmatic muscles, as Dr. Shahu had said. Of intercostal muscles, you have seen the wasting, as well as the abdominal muscles. Atelectasis occurs with a decrease of tidal volume, minute volume, vital capacity, and forced vital capacity. And we also get a decrease in mucociliary clearance, predisposing to infection. The mucus secretions tend to accumulate in the dependent bronchopulmonary segments, while the antidependent ones become dry. Then comes, very importantly, delirium. There's usually a sudden onset, maybe over hours or maybe over days, with fluctuation during the day. Usually it's more during the evening, of inattention, which means there's an inability to direct, sustain, and shift attention. So whatever you as a physiatrist or your therapist is saying or instructing the patient might have difficulty in comprehending that and carrying out accordingly. There's also a decreased awareness of environment, disorientation. The problem with that is maybe he or she is physically capable. You have made him stand up, but he has lost environmental awareness. He feels discomfort. He just wants to sit down, regardless of where he is. There's a change in cognition and/or perception. He'll start to act strangely. There might be a short-term memory loss, a language or speech abnormality, or hallucinations, auditory or tactile. In fact, a nurse was admitted to the critical care unit and she resorted to all sorts of strange behavior, like pulling out all the tubes, Ryle's tube, the endotracheal tube. She later said that she thought that her husband was standing at the end of a long alley and she wanted to go to him, but there were some wires that were connecting her back and she wanted to pull them all out. So that's basically the hallucination. It's not due to an underlying neurocognitive disorder, and these patients may have delusion, emotional lability, and sleep-wake disturbance is very common. They are sleeping during the day, which disturbs the therapy routine, and they're awake during the night. The duration of delirium in ICU patients is one of the strongest independent predictors of death and long-term cognitive impairment. It's been estimated that 20% to 80% of the patients may develop delirium at any point in time, and very frequently unrecognized or misdiagnosed. Why? When we say delirium, the image that comes to our mind is this hyperactive image. The patient is pulling out all his tubes, wires, he is very active in bed, agitated with increased motor activity. But much, much more common is the hypoactive delirium, where the patient is sleepy, inattentive, with a decreased motor activity, and we think that the patient is just drowsy or comatose, but may have delirium. And usually, between these two extremes is a mixed one. Most of the patients have this mixed form of delirium, where at times they are hyperactive, at times they are, as we call it, drowsy. So, it's been seen that delirium may occur as early as on the second day, may stay for 4 days as a mean. So 50% of ARDS patients will have delirium at ITU discharge into the ward or step-down units, and as many as 10% will have this delirium persisting at hospital discharge also. As discussed, it's independently associated with an increased risk of death in the next 6 months. It compounds the ICU length of stay, increases the hospital length of stay, increases costs as a result. But the good thing is, by this CAM ICU method, an early detection is possible. So this is the confusion assessment method, CAM ICU. So there are a number of steps. It's usually administered by a nurse or can be administered by your therapist. And at number 3, you can see that there is a RASS, Richmond Agitation Scale, which we shall discuss later. And there are some steps and pictures where the patient is asked to identify that how many pictures of the first line are repeated in the second line or third line, just to assess for his or her memory. So this is the Richmond Agitation and Sedation Scale, ranges from +4, which is combative, violent behavior, to -5, where patient is unarousable. There's no response to voice or physical stimulation. And usually in this +2 to -2 range, our intervention would be more effective. Higher or lower, the patient usually cannot carry over any information to the next therapy session. So this therapy would not be of too much benefit to the patient. Management. There's a non-pharmacological part and there's a pharmacological part. The non-pharmacological part consists of keeping the patient oriented. If he or she has dimness of vision or hearing, we should provide his or her spectacles or hearing aids. We encourage communication and reorient the patient repetitively. You are in this hospital, today is a Tuesday or Wednesday, this is the time, and I am so and so. If possible, not in our hospital actually, but maybe in some of the ITUs in some other hospital, we can bring some familiar objects from the patient's home so they will be oriented. Attempt consistency in nursing staff so the patient knows this nurse means it's a morning shift. This one is a night shift nurse. Allow television, daily newspapers, unfortunately in our ICU, not yet. Non-verbal, that is instrumental music. It helps to soothe the patient. Maintenance of sleep hygiene, that is during sleep hours, the lighting should be lowered a bit. The medications should be given so as not to interfere the patient's sleep. And also maintain a lower level of noise if possible. Of course, the alarms will always be there. The beeps will always be there. And very important, which we need to convince the ITU consultants, early rehab services are necessary, including early mobility. Pharmacological management, decrease deep sedation as early as possible. If possible, give a sedation holiday. Avoid benzodiazepines. We may use dexmedetomidine. It has a lesser effect on the ITU delirium. Antipsychotic use, possibly haloperidol does not have too much use in ITU delirium. Risperidone and olanzapine has shown use, and quetiapine has shown promise in some of the papers. Treat the underlying metabolic derangements and infection for which the patient might be in ITU for the first place, and keep him or her comfortable, maintaining a good systolic blood pressure, saturation, and control pain. Coming to CIP, critical illness polyneuropathy and myopathy. These are basically overlapping syndromes of widespread musculoskeletal weakness and neurological dysfunction, which are common in critical care patients. Presentations are similar. They can be distinguished either by EMG-NCP or by muscle and nerve biopsy, and first described in 1984 by a gentleman called Dr. Charles F. Bolton. The cause as yet is unknown. Possibly, it's a neurological manifestation of the systemic inflammatory response syndrome, maybe due to corticosteroids or neuromuscular blockers, and hyperglycemia or possibly hypothyroidism has shown an association with its incidence. Its exact incidence might range from a third to half of the patients in ICU who are staying for 7 days or longer. What do we get over there? There's a generalized symmetric muscle weakness, if you can recall the picture I showed you earlier, mostly in the proximal muscles, the hip and shoulder girdle. The facial muscles are usually spared. Rarely ophthalmoplegia would occur. And as you saw in the picture, there would be respiratory difficulties from atrophy of the intercostal as well as the diaphragmatic muscles and phrenic nerve degeneration. These three can prolong weaning time of mechanical ventilation by as much as 1 to 2 weeks. This will increase the costs, intensify the pressure on the ITU, especially in COVID times, and of course, lead to more staff being occupied over there. The DTRs may be lost or diminished, and generally the nervous system manifestations are limited to the peripheral nerves. The CNS is spared. What's the solution? In our hands, early mobilization, initiated as early as possible whenever the patients are stable. This can include progressive therapeutic activities like in-bed mobility exercises, sitting on the edge of the bed or high sitting, standing with or without support, transferring to a bedside chair and ambulation. And we can use the standard medical equipment that we use in the ward or in other places, maybe a Hoyer that's shown in this picture, to help the patient mobilize early from this bed. And I know for a fact that my other good friend, Dr. Amit Dhumale in Jupiter Hospital, he's doing a wonderful job in ITU mobilization of patients using this Hoyer, which are connected to overhead rails. So the meta-analysis shows that our intervention, physiatric intervention, has shown benefit in physical outcomes in terms of lowering of pain, lowering incidence of DVT and fatigue, a better psychological outcome, that is lower anxiety, depression, distress, a higher comfort and satisfaction, social outcomes, greater quality of life, greater independence, and organizational outcome, be it the government, be it the private sector hospital, in terms of length of stay in the ITU, mortality, as well as cost. We now need to know the cutoff limits for the various parameters that are there. Which are the patients who are safe and who are not? The traffic light system has been developed, and just like a traffic light in this expert consensus recommendation committee in 2014, they have said green means go, obviously. That is, there's a very low risk of adverse events. Amber or yellow, that is, the risk is there, but possibly our intervention would have greater benefits than risk. Red means mobilization entails a significant risk. There are many such recommendations. This is for the respiratory system, as you can see. No problem. If the patient is on endotracheal tube or tracheostomy, you can mobilize him or her in bed or out of bed. If FiO2 is 60% or lesser, no problem. More than 60%, exercise caution. SpO2, this will differ according to an intensivist. In our particular ITU, our intensivist prefers a 94% as the cutoff. In this study, of course, 90% has been given as the cutoff. For respiratory rate, it's less than 30 as per this recommendation. In our ITU, our intensivist is lenient enough. He says 35. Good. High frequency oscillatory ventilation, that's some caution. PEEP less than 10 as per this recommendation. Ventilator dysynchrony, when the patient is fighting with the ventilator is delivering an inspiration, the patient tries to exhale at that same time. Usually what happens in our ITU, these such patients are sedated, but in case they are not, exercise caution. Nitric oxide, prostacyclin, these are areas of caution, not quite used in my hospital where I'm working. Prone positioning was a contraindication for in-bed as well as out-of-bed mobility, but this has been diluted in light of COVID in our hospital at least. In-bed mobility, we see that the patients are prone for 22 hours a day. We do have to do some in-bed mobility, so we have taken the liberty. This is for the neurological considerations. For RAS -1 to +1, it's okay. -2 or +2, exercise caution. And then more or less, lesser than that, you try to avoid it. Delirium tool is there. Surgeries such as craniectomy, open lumbar drain, subgaleal drain. So these are the recommendations you need to follow. I've summarized them in a subsequent slide. This is for the surgical patients. You can see in the summary. For cardiovascular, and actually what this traffic light system does is that it challenges many of the paradigms. The intensivists, the critical care juniors, the nurses, the therapists, even us, we had some dogma in our mind that such patients could not be mobilized. But with this robust paper in our hands, we know that it's now safe to mobilize, and the literature backs it up. So this is a summary. Absolute contraindication for even in-bed exercises. Number 1, patient very agitated or combative. Number 2, an increased intracranial tension, which is being managed but has not reached the safe level. Spinal precautions, that is, the spine is unstable. There's uncontrolled seizures. Patient receiving IV antihypertensive therapy for an emergency. There's a bradycardia requiring treatment or awaiting a pacemaker. Prone positioning for refractory hypoxia. Again, this one has been diluted in our ITU for COVID patients only. And known uncontrolled bleeding. For out-of-bed exercises, these are the additional precautions where patient is unarousable or deeply sedated. There's a not clamped open lumbar drain. The mean arterial pressure is less than the target range. This says 60 as a millimeter of mercury as a mean target pressure, mean arterial pressure. In our ITU, our intensivist prefers it to be 65 anyway. That's just our system. Ventricular rate more than 150, a femoral intra-aortic balloon pump or an ECMO in place, cardiac ischemia, SpO2 less than 90%. Again, as I said, 94% in our situation. A high-frequency oscillatory ventilation, an unstable major fracture, large open surgical wound, and a femoral sheath in situ, but not a femoral cannula. So with this knowledge, you hope that things would be very smooth in the ITU, but actually it's as blurry as this picture. Why? The challenges that I've faced, and many of you who are working in the ITU might be facing, is that there's a very poor rehab orientation of the junior doctors. There's no rehab nursing concept amongst the nurses. Such chapters are maybe glossed over during their nursing course. The admitting consultants are worried about the costs, that if they ask us, especially working in a private sector hospital, our intervention, our therapist intervention would raise the costs, but we need to convince them it actually lowers the cost. 1 day of additional stay in our ITU without ventilator is almost 10,000 rupees. We can do it for much less. Even if we save 1 day, that's almost 5 or 6 days of our intervention. Number 4, conflicts between nurses and PTs. It's interesting, but it happens. There's non-availability of rehab equipment because any purchase of equipment in the ITU comes out of the ITU budget. They would prefer their own equipment rather than a hire, for example, or some vibrating jacket that will be of help to us only. And there's attrition of ITU doctors and nurses. So some of the best doctors and junior doctors and nurses are working in the ITU. They get a better offer, they leave. So all the training we have done has gone to waste. We have to start from scratch again. The hierarchy in the ITU, as it should be, is that there should be a director and an ITU consultant. Below him or her would be the admitting doctor, the physiatrist, and other doctors who are coming to check the blood sugar, the cardiologist or other doctors, maybe the nephrologist. Then comes the nurse, the paramedics, the dietitian. However, how do the nurses perceive it? They perceive doctors as a whole to be on top, along with their superiors, the ICU head nurse and the nursing superintendent of the hospital. Next is their position as per their perception. Then of equal weightage is the dietitian, the physiotherapist, respiratory therapist if you have them, the occupational therapist, ward boy, and the masi, the lady who cleans the patient and takes the bedpan. So many times it happens that they would instruct the physiotherapist just to position one patient who is not being seen by PMNR, or maybe to help in some other thing which is not the physiotherapist's work. So this creates friction. Or maybe the therapist asks the nurse to do some suctioning. The nurse doesn't want to do it because the nurse feels that doing so would mean that he or she would be subservient to the therapist. So there is friction. And it has the potential of just jamming the system, but we need to find a way out. And this is by counseling, one-to-one meeting, team meetings, we have done it. So this is some early results of some studies regarding decrease of the pressure ulcer incidences after some ITU interventions. We have got some more robust data right now. This is some success we had. There was a whiteout lung and with the intervention of the therapist actually. So you can see the air is going out after the mucus plug was removed. So prone position actually was started in my ITU after I had joined, and it wasn't so common, but now with COVID, it's quite common right now. And we do not need to discuss what are the advantages and disadvantages of proning. This is a patient who has been mobilized. He suffered from acute pancreatitis, was in the ITU for more than 3 months. And the last picture shows him after discharge, he had come around and just to say thank you. So we took this photo up there. So mobilizing patients in ITU, we have mobilized patients on ventilator. However, our ventilator is connected to the oxygen supply and it's not a mobile ventilator like the ones you'll see. However, impossible is nothing as the ad goes. And this is a picture in Johns Hopkins where they have mobilized the patient on ventilator. They have taken a portable ventilator and he or she is mobilizing in the passage. That remains a goal as yet unrealized for us. You can see him or her mobilizing with all the infusion pumps over there operated by battery. And the way to orient the nurses, to orient the intensivists, the consultants, is that to advertise everywhere. This is not our picture. This is from a hospital in the US of the benefits of early mobility, the studies which show how they should benefit, maybe some studies from our own hospital which showed benefit. So this would create awareness that yes, PMR is needed. What are the future trends? Number one, we have shown in the picture, ambulation whilst on ventilator, even outside the ITU. So that would actually be a great advertisement if that would be possible. Bathing or showering of ventilated patients in the ICU. Dr. Dale Needham, he is one of the pioneers of ITU rehab of Johns Hopkins in the US. So he or she, he is trying the same over there. Use of TV, iPad for sensory stimulation and communication. For those who are unable to verbally communicate, maybe type it out or just point to pictures in the iPad. And involving the family members as part of the care team so as not to cause the ITU delirium. In one of the hospitals, they actually have this. They hand over this sheet to the family members saying, in what are the areas you can help us? And the family member ticks the areas. So in those areas, under the supervision of the nurses, the family member actually comes into the ITU and helps the patient. This has shown to reduce the delirium. So to summarize, a huge scope exists for physiatrists in the ITU to confer physical benefits, psychological benefits, social, as well as organizational benefits. Number two, delirium is very common. We need to identify and treat it. It's both preventable and treatable. We need to keep the parameters of safety in mind whilst mobilizing these patients. And once the organizational challenges, the dogma, the infrastructural bottlenecks are overcome, then the sky is the limit. So this is the bibliography, and you can contact me. I will be very happy to share any information which I have. Thank you so much for a very patient listening.
Oh, really,
Thank you, Doctor.
Appreciate it.
Thank you, Dr. Koustubh, for your beautiful presentation. You have shared your experience. Sir, do you want to say anything, sir?
I mean, it's a very informative speech Dr. Koustubh has told today, because certain points that are really take-home messages were there. Many take-home messages were there in this talk. But definitely, our physiatrist has to be really be wondering. Many of the, including many of the senior physiatrists, also be wondering what is the role of a physiatry in the ICU, because probably rehabilitation, the amount of rehabilitation required, how are we going to initiate, how are we going to act upon. These are questions are being probably the minds of the senior people also, and it has really opened the eyes of the all the physiatrists and the role, particularly with regard to the component of this critical illness myopathy and critical illness polyneuropathy issues, and regarding the deconditioning issues. I'm really very happy to note that very important thing is mobilization, early mobility, even with a mobile ventilator. That is a real eye opener. The real early mobility is a concept that the ventilation with opening, working with the mobile internet. These are all the something that definitely we know. There a definite role will be there to define as to what the amount of mobility, what the issues that will be faced between intensivist and therapist, and there will be long of gap deficit will be there. The gap deficit has to be filled only by a physiatrist, and I really understand that the eye-opening issues, and really thank Kaushab for opening up that particular new topic. And I owe to you, Sahu, for any clarifications or doubts from the delegates or students.
So, sir, so far there is no question in the chat box. However, I want to discuss something with Dr. Koustubh. Can you little bit enlighten about CIM and CIP? How you are handling this condition? How do you diagnose that? Whether this is a pre-existing condition or it is developing subsequently? That is critical illness myopathy and critical illness polyneuropathy. Can you highlight something on that?
Yeah, it's actually what we have seen is that it develops after the patient has been in the ITU for a long time. It's not something that the patient brings into the ITU. And usually what happens, ideally, I'd like the patient to be referred immediately when he or she is stabilized. That doesn't occur. It usually occurs when the consultant is suspecting that such a condition has set in. In some of the patients, however, the patient has been referred, he or she is under sedation or drowsy. We see that there is visible muscle wasting, or the patient previously was under our care. At that time, he was able to do maybe a straight leg raising by himself, used to move his arms. Then suddenly he crashed. We stopped our intervention for 3 or 4 days. When we restarted, we see he or she is no longer able to do this or exert the same effort. So we have in our mind that maybe CIN or CIP has set in. We do not as yet do an EMG and CV, but that's only in our mind. I mean, just one reason can be that we want to minimize the costs, but this can be done. This is not something that which cannot be done. And the identification as now is usually clinical that's done. In some cases where there's too much wasting, we do CPK, CPK-MB. The CPK-MM part is not available. So from CPK, we subtract the CPK-MB to get the other one for the muscle value. We haven't seen anything remarkable as yet to, write home that maybe this patient has critical illness myopathy and the CPK-MB is raised or something. We haven't seen that. Usually they stay within normal values. Anecdotally, this is not a recommendation. We have used in a couple of patients just electrical stimulation because we wanted to get the patient out of the ITU. It has worked, but I do not recommend it for everyone. It must be on a case-to-case basis. It might have worked anyway, but we were able to get this patient out because she had just delivered and then gone into septic shock. We wanted to reunite this mother with her baby. That was one case. The other case was a young guy also. So, and we could not, our intervention could not do anything. So as a last resort, we tried that. It happened, maybe just by coincidence. We don't know. There was a question in this regard. I think Dr. Chamada Jayatunga had said that what are the options to strengthen muscles of respiration in a patient dependent on the ventilator? So shall I answer it?
Yes, yes.
Okay. So in our ITU, number one, you need to focus on the nutrition. How much protein is the patient getting? So when the patient is on ventilator, either he or she would be on a nasogastric tube or maybe a PEG tube or jejunostomy, or maybe receiving a total parenteral nutrition. You discuss with your intensivist regarding TPN or the dietitian regarding the other enteral feeds that you want a greater protein, but you do not want diarrhea as a consequence. Maybe 1.4 gram per kg body weight, 1.5 gram per kg body weight of available protein you want. With that ensured, and assuming that the patient is not sedated, the patient is conscious, able to follow commands, what I usually ask my physical therapist to do is to pick out 4 muscles, accessory muscles of respiration, and try to strengthen them. The 4 that I use most often is the sternocleidomastoid, the scalene, the trapezius, and pectoralis minor. So these are the 4 muscles that are used. So if the patient can do it, we usually move on to the other upper limb muscles as well. So these muscles, even in the COVID patients, we are focusing on. And if you are lucky, the patient gets extubated. I use the term if you are lucky. It's not a foolproof measure. Hasn't worked in every
Okay.
case. Yeah.
One more question has come up now. Is there any standard ICU rehab protocol for stroke patients?
There is no standard ICU rehab protocol, but what we do is that for the first 72 hours, or when we suspect there's a stroke in evaluation, we do not do any intervention. After 72 hours, or when the patient has stabilized, so we do start our intervention, and the mobility is as tolerated. We encourage the patient to participate in the activities of daily living, and also nutritionally, we check to see if there is dysphagia or not. For a patient who has undergone craniectomy, of course, the effort would be not to turn the patient to the side of the craniectomy, to the other side only, taking care of the preventable complications, and maybe make him or her sit up. If the ITU stay is prolonged, we try to, and the patient has some muscle power in the limbs, in the lower limbs especially, we try to mobilize out of bed, but there's no standard protocol.
Okay. Good. So one more thing from my side. Sometimes there are some conflicts occur inside the ITU between anesthetist and physiatrist. Sometimes some drugs they advise which we don't like. For example, sometimes they go for a huge doses of long-term this neuromuscular blockades, which harms the prognosis of our patients. Overall muscle weakness occurs. So you want to strengthen the muscle. They go on continuing this using this neuromuscular blockades. So how do you manage in these situations?
I'd love to say that I counsel and I convince them. The reality is they win. So we have a conversation, then I start sulking, then he says that don't sulk, just let me allow to do this for a few days, then I'll hand it over to you. So they win, then they sort of hand it over to us. I was listening to one of the lectures of one of the physiatrists in USA. What she did was that she took some pictures of some cute cats, and she used to bring them with her. And she said, every time you're using a neuromuscular blocker, one of these cats die. Please don't kill the cats. So she said it will work like that. But our person is Turner. He maybe he doesn't like cats. Anyway, I didn't try that.
Okay. In your experience, what are the dreaded complications you encounter for the prolonged ventilation in your ICU setup?
Most of the complications are related to ventilation itself. There may be ventilator-associated pneumonia, pneumothorax is there, ventilator dependency is there, there's an inability to wean, and of course, during this ventilation, since the patient is lying down for most of the time, and other preventable complications like pressure injuries, they set in despite the best efforts. There is also a wasting of the muscles despite the nutritional interventions. Because one thing that happens with high protein is that on 3rd or 4th day diarrhea starts, and diarrhea actually worsens any pressure injury that's there. So we are trying to find our way out of it. Not yet.
Okay, in the meantime, we have a couple of more questions, like one question, how to start rehab in a patient with global aphasia who is disoriented?
Very challenging. I guess, well, in the ICU, the protocol would not be too much different from what we do in the ward. So use of a communication device would be good if the patient or the family member can afford that. If the patient is disoriented, really, that would also take the communication out of the equation. So maybe just talking to the patient, instantaneously getting him or her to obey the commands during the therapy session, and well, try to decrease the factors, the preventable factors that might have caused the disorientation in the first place. If we can identify any, treat any infection that's there, treat any dyselectrolytemia or metabolic abnormality that's there. So that's that.
Okay, one more question. What are the cognitive rehabilitation approaches you would recommend?
Okay. In our ITU, actually, cognitive rehab, we are not practicing to that great extent. For this CAM ICU measure is a good thing to screen for delirium. So that's about the only tool that we are using in some of the patients who are awake, who are comprehending. But in patients who are sedated or sometimes, as I said, drowsy, it's not very possible to use. So that's about the limit of our intervention. And I'm sorry, I'm not able to illuminate you more on this.
One more question is early mobility post-stroke recommended?
Yeah, it's recommended. So generally, as I've said, we wait for 3 days, or if the stroke in evolution persists longer, we wait for a longer time. But 72 hours is more or less the standard. We wait before we commence. And
okay. What is your opinion on passive range of motion exercises while patient is being ventilated? And what would you recommend to prevent the ankle contracture? Would you recommend resting ankle and resting wrist splint?
We do use that. We do use that. Sometimes when contracture has not yet started, but patient is at risk, we use sandbags even. And the passive range of motion, if the patient cannot do it actively, it has its role. It maintains the range of the muscle, prevents the adaptive shortening that's there. So both passive range of motion as well as use of AFOs, WHOs are used in our ITU.
Okay, from my side, can you highlight something about post-intensive care syndrome? I mean, all of a sudden, after a few days or few weeks or month, after decision, all of a sudden the symptoms are worsened.
Mm-hmm.
Do you have an experience on that, and how do you manage those situations? Whether you call those patients one again, you change your rehab protocol or what?
Actually, no, because what happens is that after ICU, they usually go to the ward and then they are discharged. Only a fraction of them come back. So post-intensive care syndrome, all the facets we haven't actually gone on to identify what percentage of patients are presenting with post-PICS peaks. So we manage them in the OPD just like any other patients, as we would manage, say, a post-stroke patient who has discharged and come back. We do not have any data to share regarding that.
Okay. Any experience about telehealth program? Suppose you have discharged a patient, they are not able to come back to your institution. Do you have any experience of these telehealth programs for post ICU patients?
For not in routine post ICU patients, but definitely patients who are coming back. Maybe they have come back once, or they have contacted us after discharge. After the ICU, they go to the ward, and I take care of the patients again. Prior to discharge, I give the discharge advice. In this COVID situation, we have done teleconsultations over there. So during discharge, I just note down what are the functional areas, the functional deficits and achievements that the patient has done. Over there by telehealth, I ask the patients to do the same, or maybe at that time the therapist is also with the patient. I ask the therapist to help the patient do it and just advise accordingly, write the prescription and send by PDF. So that's in a few of the patients who have actually reciprocated and not been lost to follow up. It has occurred in the COVID times, not so much before COVID times.
One question has come up now. How can we clinically differentiate critical illness myopathy from neuropathy?
It's not clinically possible to differentiate. I think you need to do an EMG and CV or a nerve of muscle biopsy just to know the same. The features would be the same. there would be muscle weakness, the deep tendon jerks would be diminished. So it's clinically very difficult to differentiate.
I think distal weakness are more common in, and moreover, sensory symptoms will be prominent, like proprioception and sensory part also affected in more in neuropathy than in myopathy.
Okay.
Yeah. So far, no more questions in the chat box. Sir, Honorable President, sir, if you want to say something or your comments on this.
Actually, what is your team? What is about your team that you have in your setup actually?
Okay.
Describe your team. People would like to know about that.
Our core team is a physiatrist, then the physiotherapist. Dietitian is there, but dietitian is not directly under PMR department. It's a separate department, but the good thing is I'll use the word they are docile. So whenever we want to do something, we can discuss with them. They follow accordingly. There's a speech therapist also. There's one speech therapist. There are other SLPs who are more interested in audiology than speech therapy. So he comes, does a bit of swallowing rehab as well. The occupational therapist is there, but that's mostly for the ward. He doesn't enter the ITU too much. So that's about the team we have. And nurses, the nurses are dedicated to the ITU. We have done some of the training to help them position the patient, to help in suctioning. So there aren't any rehab nurses per se. And the orthotist is there for the whole hospital actually. So he's not a dedicated ITU person. So whenever we need him, he'll come, he'll fabricate or deliver a ready-made article.
Okay, good. Kaushik, this is a wonderful talk today. I think we come to an important topic end today. I really have to appreciate you. A new opening, I begin to us. Really have to thank you for taking the initiative and talking on this critical care rehab. Thank you.
So at the end, we have come to the end of this webinar. So before ending this webinar, I must thank to our president, Dr. Arasu. He has spent his valuable time and he has accepted our invitation for chairing this session. Sir, keep blessing on us so that we'll continue under your guidance this academic program. And I hope our senior faculties will cooperate us and give their valuable presentations for teaching of our students. And I must thank also Dr. Koustubh Chakraborty for his beautiful presentation. And he has cleared a lot of things in the ICU, because many of us have very less experience in working in ICU. So thank you very much, Koustubh. And I must thank to my director, Dr. SP Das, who has been a constant encourage for me for conducting this webinar. I must thank all office bearers of IAPMR and the web administrator of IAPMR for helping and propagating this webinar. At the end, I must thank all participants who have joined this webinar and asked questions, clear their queries, and thanking you all. Thank you, sir.
Thank you. Thank you.
With this, we conclude this webinar. Thank you.
Thank you.